Established treatment protocols for bladder sling health complications involve initial radiological images, including a CT scan, evaluation of the woman's medical record, review by a team of medical specialists, prescribed therapies, and then, when indicated, revision surgery, reconstructive surgery, and ongoing chronic pain treatment. Dr. Hibner emphasizes that in surgery, all of the mesh needs to be removed.
So when I see the patient with mesh injury, I do believe that mesh needs to be removed completely. And that's for basically two reasons. Number one, you can't really tell which part of the mesh is causing pain. It most likely are the arms of the mesh, not the vaginal part of the mesh. But I believe that the entire mesh needs to be removed because, again, you can't really tell. The second, probably even more important reason why the entire mesh needs to be removed is that if you remove parts of the mesh, and don't remove the rest of it may be very difficult to find. So it is much easier to remove the entire mesh in one piece rather than removing it partially and then going back in and trying to find whatever was left behind.
Following mesh removal, if there is a reoccurrence or continuation of incontinence or prolapse, a non-mesh reconstructive procedure might be indicated.
We do other surgeries than the mesh removals. We pretty much perform all surgeries that are for women with pelvic pain. For patients who had mesh removal and now they may have developed urinary incontinence as a result of removal of the mesh or sling, we work with urogynecologists that will now perform reconstructive surgery to help those patients with incontinence. Those procedures are generally done without mesh. They're generally done with patients' own tissues and fascias or using sutures without using mesh, synthetic mesh.
For continued pelvic pain following surgery, specific therapies to treat muscle and nerve pain are initiated or continued, which include physical therapy, Botox injections, vaginal suppositories with Valium, ketamine, and/or baclofen. And if needed, targeted nerve blocks can be performed with anesthetics and steroids.
Most of the patients who had removal of the transobturator sling are very happy with the outcomes, about 70-80% of them. And those are the patients that can regain the sexual activity and daily activities. They may still require some treatments. They may still require some physical therapy, or they may still require muscle relaxants or Botox injections. There is not many patients that do not require any treatments at all.
In many cases, treating chronic pelvic pain is a lifelong undertaking. Ongoing treatment of chronic pelvic pain caused by the use of mesh slings include physical therapy, opioid pain medications, gabapentin for weakness, numbness, and chronic pain from nerve damage, antidepressants, muscle relaxers including baclofen and Valium suppositories, Botox to the pelvic floor, and ketamine suppositories or ointments.
Their pain is on multiple levels. I mean, they have a centralized pain, and the treatment for centralized pain is nerve blocks and ketamine. So they get ketamine from vaginal suppositories that we use very commonly. It's probably the single most common medication that I use in my practice. And the nerve blocks, so the nerve block will block the pain. Ketamine works on the central nervous system. Those patients also have pain that is from muscle spasm, and it really creates a positive feedback loop. They have pain that causes muscle spasm, that causes more pain. So you need to break that positive feedback loop. So you do that with Botox. You try to relax the muscles. And then you do physical therapy, because physical therapy is what makes retrains the muscles. It is what makes the Botox more permanent. Now, this unfortunately takes time. When patients that start understanding that there's no magic treatment that I can do that one day, that it takes time and years of work from them, then they start understand that they will get better. They just need to put work in it.
In some cases, to treat continued neuralgia or nerve pain, a nerve decompression or cryoablation procedure is performed.
What we would do is we would do all the other treatments such as physical therapy, Botox, suppositories, ketamine. Now, if their pain continues, one of the treatment modalities would be to do either cryoablation or pulse radiofrequency ablation of one of the nerves that may be responsible for their pain. And which nerve it is really depends on which nerve we think may be causing their pain. And the way that we determine which nerve to use the cryoablation on is to do the selective pelvic nerve blocks. So in our practice, we have developed a way of blocking pretty much every sensory nerve in the pelvis, where we can selectively block them at different times or on different days to narrow down the diagnosis which nerve is responsible for the pain. And once we know which nerve it is, we can actually destroy that nerve with cryoablation.
Additionally, if pain persists, use of a spinal cord stimulator might be indicated.
So spinal cord stimulator in my mind is the procedure that is good for the patients where everything else have failed. And there's certainly patients that need that procedure. So spinal cord stimulation is a procedure that is usually done by pain anesthesiologists, and they are placing leads into the spinal cord, into the area that has pain centers, and they're able to send electrical signals to those areas to downregulate the pain impulses that go to the central nervous system.